Good morning, everyone. The webinar will be starting in just a few minutes. We're going to show some pre-webinar slides for how to access the webinar and also to put in a chat. And we will also be having some polling functions and a little word surprise during today's webinar. So please, if you're not joined with a computer, it might be helpful. If you're just on your phone, you will be able to use the polling function on your phone also. And the webinar will be starting in about 4 to 5 minutes. Thank you. So good morning, everyone. The webinar will be starting in just a few minutes. We are going to have some live polling function during today's webinar. So here on the screen, you can see the live polling instructions. If you can use your cell phone and text 22333, that's 22333, and we'll be able to put in the chat box COVID-19 heroes. And then we'll be asking one question. What is one thing that you are grateful for today? And then we will be collecting all of these things that each person is grateful for today in real time. And when we come back to this slide, we'll see all of the responses. So the webinar will be starting shortly. So the webinar will be starting shortly. Hopefully everyone will be able to participate in the live polling instructions. If you could take out your cell phone and text 22333, and you'll get a message back, and you can put in COVID-19 heroes, and you'll be able to answer one of the questions that we have for you today. And then we'll do a word doodle of everything that people are grateful for today. And so once you get that set up on your phone, if you could name one thing that you are grateful for today. And as we go in real time, we'll be hearing from each of you what is one thing that you're grateful for today. So please participate in the pre-webinar polling. So our webinar will be starting in just a minute. If you could participate in our live polling, on the screen are the instructions for the live polling. First step is text on your phone in the to line 22333, and then in the message box enter COVID-19 heroes, and then you'll be able to join in to our live polling question. And the one question is, before we start the webinar, name one thing that you are grateful for today. As you can see, we have many words coming in, and the word doodle will be a representation of everything that we are grateful for today, and there are many. Let's give it one more minute, and we will get started with our webinar, Preparing Communities for COVID-19, Session 3. We'll give it about 30 seconds. So good morning, everybody, and thank you for joining Health Choice Network and Alliance Chicago's webinar series on preparing communities for COVID-19. This is our third series, and today we're going to be again talking about telehealth. Thanks for joining. We have a number of people on the line. Our panelists will be unmuted when it's your turn on the agenda to talk. Throughout the webinar, we would like you to ask questions. So if you want to type your focused, brief question into the chat box, we will try to get through as many questions as we can during the webinar, but we may not be able to get through all of them. We will collect all of those questions and put together a document that's called an FAQ document of all of today's questions. So again, welcome. My name is Dr. Tim Long. I'm the Chief Clinical Officer for Health Choice Network and Alliance Chicago. And I welcome you to today's webinar on COVID-19. And we'll be focusing today's webinar on telehealth and using some targeted clinical approaches. But first, we'll hear from our CEOs at both Health Choice Network and Alliance Chicago. Then we will go into some targeted clinical approaches on telehealth. We'll hear from 4 different health centers on 4 different clinical areas and how this individual health center is approaching well child visits, prenatal visits, HIV and adult visits, and oral health. Then we will move into a billing and coding update that should be applicable to all health centers, irrespective of your EMR. And then again, we'll go into some resources that health centers have available to you today. So we want to start off today's webinar by welcoming again our CEOs of both Health Choice Network and Alliance Chicago. So we'd like to hear first from Health Choice Network CEO, Alex Romeo. Good morning, Alex.
Good morning, Dr. Long. First of all, thank you for joining us again during these webinar series. We've gotten great feedback from all the participants, and we're listening to your needs and adjusting very quickly to the topics and the subject matter experts that we're including these past panelists. It's amazing to see the tenacity, the empathy, and the resilience that our health centers are truly showing and demonstrating. There was no doubt from us that have been in the health center movement for over 20 years that we would be not only the first responders, but also on the front lines. I think that this has been able to highlight the mission and the focus on community that health centers have had for so many years. in the past. Our focus here at HCN continues to be very nimble. I will tell you that during these trying times, our member center priorities are changing daily. So we have implemented shifts and are working 24 hours a day, also on the weekends, just to make sure that we can respond quickly to the needs of our health centers across 22 states. So each of the states are having to deal with various conditions, shortages, and staffing issues. We also recognize that the adoption of telehealth and the strategies will forever shape the healthcare landscape of our country. We are prepared to work alongside you for funding, clinical content, research, and of course, infrastructure. We actually have been preparing our members for the Health Center of 2025 since last year, after Jim McRae and the Bureau set the gauntlet for the goals for the next 5 years for health centers. And those strategies have included our cloud-based technology, our telehealth strategies, our revenue cycle management, our value-based services, our accountable care organization, focusing on the remote worker environment, which seems funny now that we're all working from home and remotely. But that was a focus from our health center board almost 2 years ago, is to make sure the providers and clinicians can work from wherever they are and serve the community. And lastly, but certainly not least, the security of this infrastructure and this communication strategies. I will tell you that this crisis has catapulted many of these 5-year plan items and priorities from the board of directors to present day requirements. So because we've been planning for over 2 years for these, we've been able to implement these things very quickly and support our centers. I also would like to recognize Dr. Long and his team. I can tell you firsthand, they have worked tirelessly to ensure all the members of the Alliance Chicago and HCN and F2HCs at large, we've been making all content, tools, and support available to the entire F2HC family during these very challenging times, despite personal and very trying times at home. So I want to really thank Dr. Long and the team that sits behind Dr. Long for putting these together. And lastly, I want to thank you, the health centers, not only for your mission and vision, but the support you've offered. It is my sincere pleasure to work for you, to be part of this health center movement, and to recognize the fact that we are the largest primary care system in the world and should be treated as such via funding, advocacy, and federal affairs. So thank you, Dr. Long. Thank you, everyone, for participating, and stay healthy.
Great. Thank you very much, Alex. We greatly appreciate those words and also your leadership at Health Choice Network, and then more importantly, across the country for health center controlled networks. And another good colleague and friend of mine, I'd like to introduce the CEO of Alliance Chicago, Dr. Fred Rockman. Fred, are you with us?
I am, Tim. Good morning. Good morning, Tim. Good morning, all. I'll be brief. I just want to add my welcome. These calls have become a highlight of my week, and I'm eager to hear from our panelists today. The work that's going on in our health centers is personally inspiring. And at the networks, as Alex said, we believe that the rapid advances we're making and pushing forward with new and creative ways of providing care are going to have enduring impact in defining a new normal when we emerge from the pandemic. So as our speakers today are going to continue to focus on virtual care and telemedicine, as we know this is top of mind for most of you. In conjunction with this, Alliance Chicago is notifying our stakeholders of a deep discount to the paid subscriptions for DoxyMe and Zoom, recognizing that they are in widespread use. Those of you on the call who may be using free versions, please be alert to privacy and security concerns, in addition to the more functionality. That's why we want to help with access to the full platforms, as well as workflow advice and resources and tools for privacy and security. With that, let's advance to the program.
Great. Thank you very much, Dr. Rockman. And we also appreciate all of your efforts on a national level of making sure that we are on track for the future, and appreciate that. So we're going to try and make today's webinar a little more interactive. So hopefully you have the ability either on your laptop, your desktop computer, or your phone to be able to see our polling questions, and you'll just be able to put in the number. So the first polling question that we have today is, what technology are you using for telehealth at your health center? And I think if we move to the next slide, you'll have the answers. So again, what technology are you using for virtual care or telehealth? None, meaning you're not yet there. Answer number 2 would be audio only by phone. Number 3 is both audio and video enabled platform. And the last one is both, meaning you're doing phone telehealth and also video enabled telehealth. So we'll give it about 10 seconds and then we will see the actual results. I'm well aware not everyone is able to do this if you're just on your phone, but those who are on the computer will be able to. So Stephanie, can we move to the next slide and we'll see the results? So here are the immediate results, and it shows that 64% of the respondents are using both audio by phone, meaning telephone visits, and also video-enabled platform. So that's going to help set the stage for today's conversation. As we move to the next slide, and our first speaker, who is a colleague of many of ours on the webinar today from Erie Family Health Center, Dr. Roy is a pediatrician at Erie, and she is going to talk to us about well child visits. And Dr. Roy, are you with us today?
I am.
Great. Take it away.
Wonderful. Thank you so much. Are my slides up somewhere? Perfect. Thank you. So this is our plan currently for well child care at Erie at our Chicago site. This is our plan for this week, and as a disclaimer, it's already changed a couple of times and we fully expect that it will change again. But currently we are hoping to do in-person clinic visits for the babies who need their vaccines up through the 15-month boosters. We are planning on telehealth well visits for 1-month-olds to address parental issues and concerns, the 9-month-old visit to do a lot of the developmental screening, and then the 18-month as well to check in on development. And also we seem to catch a lot of people who might need vaccines and they're still a little bit behind, and so then we could organize them coming in if needed. At this time, we are planning to defer our 2 years and older for their well child care for about 3 months. And of course, if this continues on too much longer, we'll have to reevaluate whether we start doing those via telehealth as well. And I put the scales there because I'm sure everybody is aware it's just been such a balancing act of trying to prioritize, maintaining the vaccination rates for our children, but then also being mindful of the importance of social distancing and keeping people at home and keeping them safe. Next slide. So one thing that we have done is reallocate where we are doing our patient care. We do have a number of sites, and we've designated 2 of them to be well sites where nobody with fever or respiratory symptoms would be going, and that is where we would be doing our well child care for the young ones. We have urgent care sites where anybody with fever or respiratory symptoms would go, and then we have buildings that are our telehealth sites. No patients are there. It is providers, MAs, and nurses who are working there. At the well sites, we are doing our best to try to keep people as safe as possible, minimize contact. We do screen at the clinic entrance to ask again about any fever or respiratory symptoms. And if anything is positive, that visit is canceled and we can reevaluate via telehealth. If they are okay, then we do Zoom them as soon as possible, and we do their history by phone or video from another room. So it's almost like telehealth, even though they've come to the clinic. And then we'll go in and do our physical and wrap up anything. And then the MA will come in and do lab work or vaccines that are needed. At our urgent care sites, they wear the full PPE during the entirety of the time that they are seeing patients. We did some of this designation and reallocation to try to conserve our PPE and use it at our urgent care sites a little bit more, although being mindful that at this point, anybody could be an asymptomatic carrier, and separating well and sick is getting harder, but we're doing our best with what supplies that we have. And then at our telehealth sites is where the providers who are doing the video visits are located. And we are doing, the MAs are supporting us and helping us with our calls. And the nurses are there as well, reaching out to patients on the phone. Next slide. We have also changed how our providers are working, and we're rotating through 2-week blocks. So we'll spend 2 weeks doing time seeing patients in person, and then we will spend 2 weeks doing telehealth. So in this rotation, it's sort of a built-in quarantine in case people are getting sick and need to stay home. And we always have a source of providers to call upon if people do get sick and need to quarantine themselves. So far that's been working well. Next slide. So all the video platforms, it looks like a large percentage of you guys are already using the video platforms and so are familiar with a lot of these things. Erie has not yet gone towards one unified platform that we've paid for, but we're definitely looking into that. Many of us, I would say, are using Doxy.me, also Zoom, and many of you may have noticed the Doximity dialer that a lot of us use to call patients added a video function just last week, which is great. And then when all else fails and we're having difficulties, a lot of times we will use FaceTime and Google Duo, depending on what types of phones people have. One thing that we found with the Doxy.me, and I think speaking to people who have the paid version as well, the issue when you're doing telehealth and trying to get an exam and see things, the parent will often try to flip the camera from front to rear to show you what's going on, and then the call disconnects. So that's just helpful to be aware of, and maybe that will hopefully be fixed soon. I don't know, but that does happen. FaceTime obviously is not the ideal and is not anyone's first choice, but sometimes when everything else is failing, we do resort to that. But I think an important tip is that you can change the caller ID that shows up to an email, and you can make it your work email. It's still not ideal, but it's a little bit more anonymous than having your personal cell phone show up. And if you want to know how to do that, it's pretty easy to find on Google. And then in terms of a couple of these platforms like Doxy.me and Zoom, you do need to send the link to the patient so they can start. And I know in Doxy, you have to pay to be able to do it through, to text through Doxy, but, we're still using the free version, and it doesn't mean you can't text the patient in a different manner, that link. And so we have been using care messaging to send the link. And so we still have a free Doxy.me. We just text that link to the patient using a different method, and then they call in. So we've been using care messaging, and also there's an application that's free called Text Free. So many of our providers are using that. We just keep the link to our own Doxy.me saved as like a note in our phone. And then when we are contacting the patient, we'll text them that link and they can just open it. Obviously, you can do this over email, but we have found that it's been much more efficient and works better for our patients if we are able to text them the link to the platform. Next slide. So, things that we have found, probably many of you have since you're doing this, 2 screens are very helpful to have next to each other. Sometimes I think you just have your laptop and you do split the screen, but if it's possible to use a tablet or a phone or even a second laptop next to each other, it's very nice to be able to see the patient and then chart in your EMR simultaneously as you would do in a normal visit. And if you are doing that, if you're doing it in clinic, as many of us are, it uses up a ton of battery. And so just to remember, bring your charger for your phone or your tablet. And headphones have been very helpful. It keeps you hands-free and then keeps the workspace quieter as well in terms of not hearing the patient. Everyone can't hear the patient. So one thing that we've been doing at Erie for our telehealth visits when we are doing them in clinic is MA support. So they are helping us by, at the appointment time, they are calling the patient. They will obtain the consent for the televisit. They will ask them for any vitals that we can get, namely at this point, if they have a scale to get a weight. Unfortunately, we find that a lot of our patients don't have scales at home, so it hasn't always worked out, but if possible to get a weight for us, and if they could check a temperature, they will send the link to the platform to the patient and start the EMR document for us and put in a lot of the the COVID screening questions and do the basic intake like they would in a visit, a normal visit, and then they route the document to us. We'll log in, we'll find that the patient is in our Doxy.me waiting room, and then we'll start our visit. Next slide. I would say that it's been working really well, and it's almost surprisingly across the board, people like it a lot, both providers and patients. And so I think as we've been talking about, a new norm after this, I really agree. It really is amazing how much you can accomplish, and people are very thankful that they're able to get their care taken care of without leaving their house. The negatives are probably the technological frustrations that come up a lot. And so one of the things is, I think listing all of those platforms, I found that it is helpful to have some experience and be sort of facile in using a few different ones, because almost every single day I've been doing telehealth, at some point the audio is just not working, the video is just not working. It is very helpful to have like a backup list in your mind of which things that you could use when something's not working. But in general, when the video is working, we found for well visits, even though we are trying to see most of our babies in person, when we are doing it via tele, it's amazing how much you can see in terms of developmental milestones. You can see the 4-month-olds trying to roll, the 6-month-olds trying to sit. You can see them trying to pull up. I've been amazed at how much I can assess, at least from the development standpoint. The physical exam, I imagine, for everybody is the part that's most challenging, the most different. And so things that we found that we can, it's working together with the parent to try to see how much we can get and teaching them how to do things. And so showing them where the pulse is and showing on yourself what you need them to do is helpful. And so you can help them see where a pulse is and kind of count it out and get a pulse that way. And obviously, if you can watch the child breathing, you can get a respiratory rate. One tip is to just clarify with the patient which side of their body they're pointing to, if they're talking about their right ear or arm, because with these, depending on what device they're using, like a phone or a tablet, you may be seeing a mirror image or you may not. So it's actually a little bit more confusing than you would think. So it's helpful to just clarify that. With the little ones, it's definitely helpful to ask the parents to take their shirt off. You can see a lot more in terms of skin findings, assessing their respiratory effort, checking their abdominal inspection for distension or anything like that. I will say I find that the older the kids are, the more they're resistant to it. It's not comfortable. Everything was going great up until that point, and they really don't want to take their clothes off in front of their parents' smartphone, which I don't really blame them. So that's a bit of a challenge. I think that's why telehealth works really well for acute and focused visits when there is an issue, and it makes much more sense why they would be showing me one particular thing. But I think it has been challenging as they're older to ask them. So I don't force it, but so it's a challenge. Definitely, I think you can the parent can palpate the abdomen and you can show them the different quadrants, and that has worked well to try to figure out where someone has abdominal pain. I think a good tip is asking a patient to jump up and down. You can assess a lot by doing that, plus kids love to do that. You can rule out an acute abdomen. If they are calling about respiratory or asthma issues, you can see a lot by if you ask them to do some activity and then reassess their respiratory status. So that's been helpful. And then keeping in mind that pictures are still very useful. There's a lot of times we're talking about rashes or something. And so if you do set up your phone to have one of these free texting apps or through your email, if it's secure, if you can have the patient take a picture of a rash or something else that you were talking about, it is very helpful if they can email it or text it to you, and you can get a much better picture. And then in terms of the oropharynx as well, it's pretty hard to see on the video, but when you ask the mom or dad, ask them to open and look, it's amazing. They'll actually be able to describe what they see. And if possible, you can ask them to take a picture, use a flashlight, take a picture and send it to you, and then you can see it as well. It's a bit hard to get it on the phone video. Next slide. So it's overall been going well. We're reaching out to try to increase how many patients we are seeing. We slowed down once this all started, and so people have missed some well child checks. So we are sending messages just that we are open for well visits if people want to come in. We do find that a lot of people are hesitant, and so even though we want them to come in, I think a lot of these are going to be converted to telehealth because people are hesitant to leave the house right now, and understandably so. We're doing queries to find out who are the people behind on vaccines so we can reach out to them and hopefully do things like just have them come for a quick visit to the lab in and out. We're finding that telehealth is a good opportunity to do a lot of follow-up appointments. So running lists of people who have asthma, ADHD, and reaching out to schedule follow-up appointments. And those have been going really well. And then initially we had tried to think about drive-by vaccines. Being in the middle of Chicago, it's a bit challenging because most of our sites don't really have a large parking lot or driveway or a lot of empty street space where people can wait in their cars. And so it's a bit of a challenge, but we're hoping that maybe a couple of our sites might be more amenable to that. And we're thinking in the future, hopefully the near future, we can figure out how to do some drive-by vaccines as well. Next slide. Okay, that is what we are doing for Well Child Care at this point at Erie. Thank you very much.
Great. Thank you very much, Dr. Roy. That was extremely informative, and I'm sure people really appreciated that. We did get a number of questions in the chat box, and I think we're only going to have time for one question, Dr. Roy, if that's okay. And for those of you who did ask questions in the chat, our staff at the network will be collecting all of those questions, collecting the answer, and then packaging them up into a document. So Dr. Roy, one of the questions that came in for you was, when you're doing the Well Child visits using telehealth, how are you billing?
Well, that is a wonderful question that we keep talking about every day. So I have been told that if you do it and you put in the well and you say that it was via tele, the correct, what do you call it? The modifier will be added. You know, we have a billing department, right? So we are told, you click off where you were, did you do it telehealth? Were you in the clinic? Not. Were you video? Were you audio? So we check off how we did it. And then we check off that we did a preventive visit. And I think when our billing department processes it, they add the modifier that the Well Child was done remotely or via tele, and it is submitted. So it's literally a question I've asked almost every day. I know there's been a lot of confusion about whether preventive telehealth is actually covered or not, but I've been assured that it is. And so I'm just doing what they tell me to do. But I believe it is covered, and you do bill it as preventive. It just has to have the appropriate modifier.
Great. Thank you, Dr. Roy. You answered that like a true clinician. I appreciate it. So thank you very much. And we will be, again, as I mentioned, collecting all of these questions and getting the answers back to everyone who has joined on to today's webinar. So if we move to our next slide, we're going to again do a polling question. I know not everybody is able to answer the polling questions. You would need to be signed into the webinar and see the screen. So if you're just listening via audio, unfortunately, we will not be able to get your polling interaction. But our polling question number 2 is, what video technology platform are you using for telehealth at your health center? And it could be DoxyMe, WhatsApp, Zoom, Microsoft Teams, or something other than one of the above. We could only put 5 on there, and you can select more than one if your health center is choosing. So the poll is open. Again, it's, what video technology platform are you using for virtual care at your health center? You can see the choices there, and some health centers are using more than one, so you can select more than one. So we'll give that 10 seconds. Have everybody join in to poll number 2. And Stephanie, could we see the live results of poll question number 2? And as you can see on the screen here, the answer to what video technology are you using, it's a pretty near even split. First, Zoom is coming in number 1 at 50% of the respondents. Then DoxyMe at 41%. And both WhatsApp and Microsoft Teams are at 5% equally. And then we have 28% that did put in something other than one of the 4 choices that we offered there. So thank you very much for those responses. So next, we're going to turn it over to another one of our colleagues, Dr. Loberg from Friend Health, who's going to talk with us about how do we do telehealth during this COVID period with our prenatal patients. So Dr. Loberg, are you with us?
I am. Can you hear me?
Yes, perfectly.
Great. Well, thank you so much for having me. This is a really great meeting of the minds, even though I can't see any of your faces someday. So we set out with the following goals in place. We wanted to protect our patients and ourselves, maintain our quality of care, and also we almost instantly had a lot of people who were home quarantining, but well and eager to contribute. So we wanted to try to maximize what those people were contributing to the team. Go ahead and send to the next slide. The first thing we did was try to, because we have schedules out for months and months, to try and scrub our schedules and redesign them. And when we're looking for guidance from our leadership bodies, ACOG put out an FAQ on COVID and says, can we do telehealth? And they were like, yeah, great. They're encouraging us to do it. There's not much more specific guidelines about who should do it, where they should do it, what types of patients should do it. So this was our first pass. We said to our call center, these are some people that you can schedule right away for in-clinic visits. These are some people that we just want you to put on the schedule in about 2 months. Anybody who's coming in for their pap smear, wants to have a hysterectomy, just tell them to hold off a month. And then these are all the people that we want to be triaged through our virtual visits or the prenatal visits that we've deemed appropriate for phone calls. And that's pretty much everything else. You can see that for our automatic scheduling for in-clinic visits. We did STI treatment that needs to be an injection. We went back and forth on depot, and I'll talk a little bit more about some of our solutions there. And for our preeclamptic patients, we did authorize a 1-week postpartum blood pressure check, although I'll address some of our BP solutions in a little bit. Next slide. I know it's a little tough to see, but here's generally how we've mapped out our goals for each of the main prenatal visits and whether we think they can be virtual or in clinic. For our new OB intake, that can happen either virtually or in clinic. I often see a lot of our virtual visits as triage opportunities for an in-clinic visit. Many of them will result in scheduling of an in-clinic visit, and others will result in knowing that we can defer that in-clinic visit for a number of weeks. So we were doing a lot of our new OBs virtually, collecting a past medical history, collecting their medication, screening them for high-risk issues, getting their orders in. We can start the ultrasound scheduling process over the phone, sending their prenatal vitamins, and even getting some estimates on their dating. We did give our patients the option of coming in for lab draws only. That does include coming to the clinic, and so we would give them some education about what screening they would anticipate at the clinic, how to go to some of our lower volume sites where there would be less potential traffic, and times of day when they can do that just to pop in, drop a urine sample, and go. We would try to coordinate our visits for when we would need to do a blood draw. So around 15 weeks for genetic screening or earlier, depending upon which genetics they had determined they wanted to do. That's something that they would triage for during their new OB visit. So some in-clinic visit during the first trimester for genetic screening, pap smear, physical exam. And then for 20 and 24 weeks, we said we would do another virtual visit, this pushing our glucola and third trimester screening into one visit around 28 weeks. That could also be coupled with their Tdap and their RhoGAM if indicated. So one big visit for blood draw, glucola, and RhoGAM. We worked a lot on where to have our patients wait for the glucola. They need to drink the glucola and then have their blood drawn an hour later. And so we are offering people either wait in their car or creating isolated waiting area where they can wait alone for their hour so that they won't have to be in any public clinic space. And that did require some logistical changes for us. In the third trimester, we have people coming a little more frequently. And again, that's going to be titrated to any of their high-risk conditions. One of the ways we tried to enhance our home visits, we worked hard with our pharmacy to try to get blood pressure cuffs for all of our pregnant patients. And, routinely we would do this for anybody with chronic hypertension or gestational hypertension that we wanted to be screening at home. But our pharmacists, they do home delivery, and we are working with them to get blood pressure cuffs for all of our pregnant patients so that as part of our virtual visit, we can do BP checks. And to facilitate more third trimester, when patients are coming in every single week in traditional prenatal care, or we could call them once a week and have them do a weight check and a blood pressure check, screen them for fetal movement and contractions, leaking fluid, bleeding, a routine review of systems for a pregnancy visit, and have that be a virtual visit. One of the things we thought we were sacrificing by going to a lot of virtual visits, particularly in the third trimester, was pre-eclampsia screening. So getting those blood pressure cuffs out to people has been really helpful in providing us the reassurance that we're still providing that quality of care. Also, some of the things that we do in clinic, we're working on supplementing at home, having nutritionist visits, having a behavioral health counseling visit, and our lactation support colleagues are getting more of those supports online as well, so linking them in with some of the virtual health that's being developed for lactation support. And we did a lot of modifications to our workflow, just like Erie did, but we have well pathways within our clinic, so our well patients and our OB patients use different entrances, they take different hallways. We try to physically separate people who are for walk-ins or urgent visits from our well patients so that they are not crossing paths or touching any of the same surfaces. Additional changes to our waiting room, essentially. There are no patients left in our waiting room, but initially we had moved chairs around and things like that. Next slide. Again, we're looking for guidance from our organizations about what to do. This SMFM and ACOG workflow, you guys have probably all seen a lot of our virtual visits or triage calls with our pregnant patients are specifically about coronavirus. They're concerned about how it's going to affect their pregnancy. They want to know if they should go to the hospital. They want to know if they need to come in for an in-clinic visit. And just like they had with influenza, it's very similar to their influenza workflow. It allows us to comfortably screen our patients over the phone to determine if they need to come into the hospital for evaluation or if it is safe for them to continue home care. So it allows us to screen them for both high-risk medical conditions and high-risk symptoms that would prompt us to do an in-hospital evaluation. I know this is mostly about prenatal care, but we also got some good guidance from the ASCCP about how to safely defer colposcopy for people who have abnormal cervical pap smears. And that was really reassuring too, just to give us that sense that, yes, we can wait 2 months for this. Yes, we can wait 6 months for this. We can tell our patients that we can do that confidently. Next slide. Another thing that comes up very frequently and has been a little bit more difficult to navigate is how to provide our patients with workplace accommodations. And I think it's difficult outside of the pandemic to get our patients adequate workplace accommodations because a lot of the recommendations are not very strenuous. And that's pretty much the case with the coronavirus as well. Both the CDC and ACOG came out with statements about pregnant people in the workplace. These two statements both refer to pregnant healthcare personnel. These are people who are likely to come in contact with both well and sick people. And they basically say that they should take the same precautions that a non-pregnant person would take in contact with both well and sick patients, and that employers and facilities should do what they can to limit the exposure of pregnant persons to confirmed or suspected coronavirus patients. So it leaves a lot up to the discretion of the employer. And we're seeing some of my patients have been granted accommodations and some of them have not been granted accommodations. But one of the things that we have developed, and actually you can go on to the next slide, this is sort of our personal to-do list, exciting challenges and opportunities for growth. These are things that we have encountered that we have, I think the name of the game over the last few weeks is like change and more change. These are things that we have invented and reinvented on a daily or weekly basis. Initially, when you asked about billing, I can answer that. We have created a visit type for virtual visit that allows our billing and coding people to identify when we were doing those visits virtually. So we created some new templates for that, and our templates have a lot of redundancies in them. Our in-clinic templates have a lot of redundancies in them because we have a high no-show rate. And we use those same templates for our virtual visits, and our show rate for virtual visits is almost 100%. So we made some modifications there really quickly. We created a lot, and Dr. Long sort of a role model for digital tools, quick text. We created a ton of new quick texts and letters and a system for sending letters to patients at home. A lot of pregnant patients need FMLA paperwork. People during the pandemic need a lot of notes for work and FMLA paperwork. So we created a virtual pathway. We created new email addresses, new fax numbers, new people sitting by those desktops to process that. We've had, our roles for MAs have changed enormously. We don't have them doing on-the-phone triage. This was challenging. We're trying to meet all our UDS measures while doing this. So we're learning a lot about what our MAs do, screening for smoking and PHQ-2s and things like that. But we're getting our MAs to do more of the paperwork role, more of pre-visit screening. And again, I mentioned our pharmacy has been a huge tool for us. One of the challenges has been LARC, tubal planning, birth control. Our hospital is no longer doing post-vaginal delivery tubals, but they are doing post-placental IUDs and other LARC. So patients who had been anticipating that tubal all pregnancy are now being recounseled. We also have worked with our pharmacy to get sub-Q depot for home administration. So they're doing home delivery of sub-Q depot. We're working, and we have how-to videos for home administration. And we're setting up virtual visits so that we can help the patient navigate that first injection. And that has been going fairly smoothly. Getting our patients early enrolled in WIC has been a project that we've been working on with our pediatricians. Patients are going home from the hospital sooner after their delivery, postpartum day 1 after a vaginal delivery. So we're seeing that patients need a little bit more breastfeeding support, more weight checks for their babies, and getting help enrolling in WIC earlier, who also has limited hours and more phone opportunities. So re-educating people on that process. The other two, interpreters, patients in crisis, we're developing a identification system. You know, on your virtual visit, you call somebody and they're speaking a language you don't know. How to flag that chart in anticipation and make sure that you have an interpreter on the phone with you. And that has been a new way of using some older technology. Our phones we would normally have in the clinic with the patient, how to link those in with our phones we're using for telehealth. So I would say overall, our experience has been very successful. We're actually very, very busy doing telehealth visits. Our patients are very, very grateful that they're having an opportunity to have their needs met quickly and virtually without coming in. And our providers are grateful for the opportunity to be able to work from home when they have been quarantined, so they don't have to take all this sick time or leave time. You know, to continue caring for their patients while they're off. Happy to take any questions that you guys may have about what we're doing for prenatal care.
Great. Dr. Loberg, that was absolutely fantastic. I don't think there were too many questions in the chat right now, but we will look again. And if there are, what we will do is package them up and email the responses out to everybody. So I want to thank you very much, Dr. Loberg, for this excellent presentation on prenatal care in the era of COVID, and all of your colleagues at Friend Health. So thank you. So I think we're going to advance the slide now. And so next we'll hear from myself. So here I'm going to be wearing my hat as a physician internist at Near North Health Service Corporation. And here at Near North, I currently only see patients on Friday, so 1 day a week. And my main focus of care and treatment at Near North is with chronic disease and HIV, and predominantly an African-American patient population on the south side of Chicago. Near North does have 8 primary healthcare sites, but currently I'm seeing patients just at one site just on Friday. So this conversation is targeted to my experience at Near North and how we've incorporated both adult chronic disease management along with HIV into telehealth and care. And just as an aside, I had dinner with my friend and colleague about 6 weeks ago Dr. Stephanie Cox, who is the Chief Medical Officer at Near North, and asked her about how are we going to set up telehealth. And I was very much itching to move forward with telehealth, and she promised me that we would have telehealth by the end of the calendar year, and I was extremely excited that that was going to happen. Little did I know that about 2 weeks later, we were up and running with telehealth. So, and the experience has been overwhelmingly positive so far. So Near North did choose the platform for both video and with the WhatsApp application. And some of that was because, yes, it's free, but I think it was very common among many providers and also patients that WhatsApp was not a challenging application to understand. And I think one of the things that I really appreciated about WhatsApp is that I did know it. Most of the providers already knew about it. It's not something we had to download. We didn't have to get trained on it. It was very, very easy to use. And I know, as many of our colleagues have said prior, this may be the platform that Near North is using today, but it might not be the platform that we're using a month or 2 or 3 going into the future. As we look to after COVID, certainly we want to have some network-wide telehealth services that all health centers can join into, and larger than just an individual health center. So one of the more important elements for at least my patients at Near North was I have a very involved care team in managing some very complicated HIV patients and chronic disease patients. So I'm very fortunate at Near North to have a team working under a Ryan White funding that allows us and me to have additional staff to help care for these HIV patients. So our workflow generally has been, before telehealth, is that every patient, after they exit the exam room with me, is handed off to a live person who then discharges that patient. So that could be going over the office visit summary, scheduling their next appointment, ensuring that they know to go to the lab if labs are ordered, or if there are other forms or paperwork that needed to get filled out for their HIV medications or other chronic illnesses, like getting some home monitoring devices. So I think one of the most important things then in moving rapidly to the telehealth platform WhatsApp was how could we make sure that someone from the care team was involved in that process. So in the WhatsApp application, you can have up to 4 individuals on the WhatsApp video virtual visit at one time. So what I do is I use my work cell phone to have the video contact portion with both the patient and also one of the care team members who is listening into the conversation. And oftentimes we have a medical student who is also on that video call to also be a part of their learning, but also helping with patients. I think that has been very, very helpful because it seems like the patient is still getting that discharge summary, because after I leave the video-enabled WhatsApp call, the staff person and the medical student stay on with the patient to do that discharge planning, which means we might have talked about ordering labs, getting some x-rays or radiology or imaging, or filling out paperwork, and then the staff can make sure that all of that is done. Specifically, many of these patients do need to have blood drawn frequently. So since they're not in the health center, and I'm actually not in the health center either, but the care team members have been in the health center, we do arrange to have the patient come into the health center at a time when the volume of patients is low. And also we know when the patient is coming in to have that pre-ordered blood work done. So if there is any signatures or paperwork that need to get filled out, we accomplish that at the same time. So the workflow has been pretty much the same as we were before we were doing telehealth. There are the pre-visit preparations for the patient and the care team. This happens about 3 to 5 days before a scheduled visit. And for patients who do not have a scheduled visit, then they don't get that pre-visit preparation. However, they are put on the schedule. But the team does feel that pre-visit preparation visits are very helpful to make sure that the patient understands what is the primary intention for today's visit, and then we can collect other records or things that we need to. So we were able to incorporate the WhatsApp discussion and whether the patient preferred a video-enabled visit or just a phone call for their visit in that pre-visit preparation visit. Then the staff person would put into the patient's chart and in the EMR that we're using, we have the ability to do something called a pop-up alert in the chart. So if anyone goes into the chart, we'll see this alert. And on that alert, the staff person would put the phone number that the patient wants to be contacted at, and it may be different than the patient's phone number in registration. They put the name and phone number of the staff person who's going to be joining me on the video-enabled WhatsApp chat visit, and also the medical student's name and phone number. And so the care team did not want to give out their own phone number, so they have all signed up for the free Google Voice phone number. So it's a real but fake phone number that we're using during this temporary time. So their phone number is not actually going out to the patient. My number is going out to the patient, and that is intentional. And I do want my patients to have my phone number because I do want them to be contacting me if there are urgent things. So this has been really no different than what we were doing before. In looking and wanting telehealth for a long period of time, I am continually amazed at how great it has been for the last 4 weeks that at least I have participated in it. I do think that we are able to engage our patients using the video much more than the telephone, obviously, but it brings me in the picture onto their phone into their home. And all of the patients have commented how much they appreciate that, how much they appreciate our care team at Near North reaching out to them and asking them if they would like to have a video visit. I would say probably about 85% of patients have agreed to have a video visit rather than just a phone visit. And I think that just is a little more interactive than just a telephone visit. And I think the follow-up after the visit has been great because we have that third and fourth person on the video visit, because then after I leave the visit and going on to the next scheduled patients, they are working with the patient to make sure that everything is done. So it's very similar to a virtual after visit summary and reviewing what was done at today's visit. One other thing that I didn't get a chance to put on the slides here is for those patients who do have home monitoring for their blood pressure or their blood sugar, having a glucometer at home. During the pre-visit preparation phone call, we do ask them if they have hypertension or diabetes, that they would check those two measurements at home the morning of their visit, and then we verbally talk about that. Then I will document those self-reported home-taken outcomes into the EMR. I know that that's not going to be counting for UDS, but it's really, we at Near North are first looking at clinical care, engaging our patients, making sure our patients are healthy, and then we will also figure out the billing and all those things in UDS after this period. But really, we wanted to make sure that we got something up and running and continuing to engage our patients. We at Near North have seen a reduction in patients coming into the health center, like basically every other health center in the country. So I think that's it for my experience then at Near North, and I think it's been overwhelmingly positive. I'm really looking forward to the next steps of telehealth, not only at Near North, but also across our networks together, and how we can start using this technology to change the way we deliver healthcare in a much more, I think, patient-friendly manner. The amount of time that the video visit saves the patient from coming in to see me and our team waiting has really, I think, been a very tangible benefit to our patients at Near North. So thank you for that time to allow me to talk about HIV care and chronic disease in adults at Near North. And so I think we're going to move to the next slide now, Stephanie. And here we're going to hear from one of our colleagues in West Hawaii. And I want to thank him, first of all. It is very early in the morning there. So thank you, Stephen Pine, for getting up earlier. So Dr. Pine is going to talk to us about how West Hawaii Community Health Center is managing dental visits during this period of COVID. So Dr. Pine, are you with us?
I am. Can you hear me?
Yes, great. Take it away. I think your slides are on the screen.
Perfect. Well, thank you very much. We here at West Hawaii Community Health Center have been doing teledentistry for about 3 years now. With the new outbreak that has occurred, we have modified our teledentistry technique according to the new guidelines that have been issued by the American Dental Association. They were recommending a couple different codes to go along with procedures that we could be doing for our patients, preventing them from coming in. Traditionally, we had done the asynchronous visit, which is the D9996 code, which is when we have a team member out in the field, a hygienist and assistant, taking x-rays and doing the cleaning on a patient, providing that information to us, and later one of our dentists would review those x-rays and determine if the patient needs to come in or not. With the new guidelines that have been placed or put out, we've decided to modify that so that when we have patients who are calling into the clinic, we can evaluate them as to whether or not they do need to come in to see us, if they can stay out there and we can treat them without them coming in to the clinic, or to do post-operative care. So if we could flip to the next slide, please. So for teledentistry, case selection is very important. The American Dental Association has said that we can do this for new patients. We still, though, would need to have all of that documentation, the new patient paperwork, health history, all provided to us to obviously be able to do those visits. Here at West Hawaii Community Health Center, we decided to perform synchronous teledentistry on just our established patients with current health histories. We're typically doing these for those limited oral evaluations and for the reevaluations post-operatively. Our front desk team helps screen calls for the possible teledentistry visits. And the front desk will inquire with the provider and then schedule the patient for a teledentistry visit if it's applicable. A couple of things to note here is that just because the federal law has been relaxed, our state laws haven't always caught up to that, even with the coronavirus going on. And we are lucky here in Hawaii that they have caught up to that and they are allowing us to do that right now, but it's something to check on in your own state. And it was also made aware to us that there's the possibility that CMS will not pay for a non-emergency or non-urgent visit during this time. So we do want to make sure that these visits do fall into those categories. Furthermore, for our state and our regulations, it was explained to us that we need to be operating in what is called a hub and spoke approach. So that's why we have our front desk helping to screen these calls and to actually then schedule the patient on our schedule for those visits. Our providers are in the office during that time, with the patient being external to the office. Go ahead and flip the slide, please. Thank you. So prior to the visit, the front desk will email the patient information on what to expect during the visit and the limitations that we can do with teledentistry. Clearly, we cannot be there fully evaluating the patient, but it is a tool to be used, and so we do want our patients to understand that. 5 minutes prior to the appointment, the front desk will contact the patient and help set up the visit if it's needed. Some of our patients are obviously very good with the technology, and some need a little bit of help and coaching along the way. During the visit, we're actually using the tablets so that we can chart at the same time in our EHR record. We're using Doxy.me, and it's worked out pretty well for us. There's always a little glitches with these things, but it has been working pretty well, and patients have found it very easy to use. One thing we want to make sure of is that our patients are in a safe space to talk, and that the phone and computer is on a selfie mode so they can actually see the screen. Since they're going to be showing us stuff in their mouth and on their face, we want to make sure that they can actually see what we're seeing so that we can ask them to perform various functions to provide them with the best possible care. We also want to remind the patient to wash their hands after touching their phone and getting all of this set up, because we will be asking them to stick their fingers in their mouth. We'll clearly perform the examination and do medications review, medical conditions, social conditions, allergies, dental history, all with the patient. We'll then determine if a follow-up is needed and any next steps, whether that is prescribing medication, setting up a follow-up visit when this is over, or needing to have the patient come in. And we also want to remind our patients to wash their hands, of course, when they're completed after they've had their fingers in their mouth. After the visit, we drop the appropriate charges that we normally would, then with the corresponding teledentistry code. For us, because we're doing this synchronous, we are dropping the synchronous teledentistry code. It's also recommended to add a template to our typical note, identifying the visit as a teledentistry. HCM has also provided an example of that as well. I think they came out in the past day or two. Next slide, please. A few resources here that I found valuable was the ADA website. It has a lot of information right now regarding teledentistry and how to code and bill in this interim time period. The National Network for Health Access also has a lot of great resources on there. They did a webinar here recently that was very good, and there is a link to it on their website. I would recommend watching that. Mouthwatch as well is a company that does produce intraoral cameras for those who are FQHCs who are doing oral health. They have a very good and affordable intraoral camera, but they do a lot of teledentistry stuff. And so you can actually go on their website and they have a very good guide you can provide patients on positioning to be able to look at the oral cavity and to tell them what to expect. There's also a few other interactions that can be done that we have not explored yet, but a few ideas, and that is possible patient MD and BDS interactions, where the patient is at the medical doctor's office noticing something, and then the medical doctor is calling and can do a teledentistry visit with the dentist at that space. So a couple of health centers I know are doing those interactions right now, and it has worked out really well for them as well. Thank you very much.
Great, thank you very much. This is very, very useful, helpful, and also timely, as a number of health centers are struggling with how to truly incorporate teledentistry into our community health centers. And I think there'll be more to come on this even after the COVID period. So thank you very much. We have been collecting some questions, and we will be putting them into a FAQ for all of the questions from today. But from our last webinars last week, if you look on the webinar software on the page, on the right-hand side, there'll be a section where it says handouts, and that's where you can download today's slides and handouts. And also you can download the questions that were asked from last week's webinar. And some of the questions are rather similar. So I would encourage everyone, if you want to get those documents, you can just go to the right-hand side of your screen and go to the bar where it says handouts, and that will expand down. And then there's a number of handouts that you can download to your computer there. That's in addition to finding them on the resources section that we'll talk about shortly. So if we advance the slides, and we're going to move to our next polling question number 3. And again, I apologize for those who are just on phone audio. But the polling question is, are you or your health center using telehealth for, and then choose all that apply. So in your health center, are you using telehealth for routine primary care and or acute sick and COVID-19 patients, chronic care management patients, oral health, and behavioral health? I think on the next slide, you'll be able to choose all that apply to what your health center is using telehealth for currently for routine primary care, acute sick or COVID-19 patients, for chronic care management, for oral health, and behavioral health. And we could only have 5 answers, so I apologize about that. I know there might be others. But we are limited with the 5, so we'll go with that. So Stephanie, why don't we go ahead and turn over the results to this poll question number 3 and see all that apply for health centers. So here it looks like a majority of people are doing behavioral health, which is great. 90% of those responded to either doing telehealth or behavioral health. And a close Second, with routine primary care at 86% of health centers are doing that. And then a near tie for the acute sick COVID at 75%, chronic care management at 74%, and the oral health coming in at 28%. And that probably is some of the challenge that we were just talking about. So great. Thank you very much, Stephanie, for that. And we will now move on to our next agenda item. And here we're going to hear from some of our colleagues who hopefully might be able to answer some of the questions that the providers had on telehealth billing and coding updates. So telehealth billing team, I'm going to turn it over to you. I'm not sure which one of the three of you are going to talk first, but I'll let you guys introduce yourselves.
Good
Terry,
afternoon,
Lynn, or Jordan? Perfect. Take it away.
Good afternoon, everyone. This is Lynn Wiggins. I'm with Greenway Revenue Services. I'm a Senior Practice Advisory Manager here, and I've worked closely with Terry Rios, and we have been working with deciphering all of the updates that have come in rapid fire over the course of the last few weeks. So we've worked together very closely trying to establish meaningful workflows and information. So thank you for advancing. This is the first slide that I was wanting to share kind of in a nutshell with some of the items that we know are being most affected by the 1135 waiver. And I really appreciate what the provider said earlier about, understanding the difference between the federal mandates and updates versus your local updates. We do understand that when the updates are coming from CMS, this is Medicare only. Medicaid is still making their in-state decisions. Sometimes they are following CMS recommendations, but often they are not. So it is quite necessary that we do understand that those the Medicaid payers, the commercial payers, they are not inclusive of the waivers and the updates that's been sent out by CMS at rapid fire lately. And when I say rapid fire, I know you all do understand that we're getting updates sometimes on a 24-hour cadence. It may be at 1 p.m. on a Sunday afternoon or a Friday evening. So this information is very, very moving very quickly and has become somewhat of a moving target. I want to go back to one of the questions that was asked earlier about the preventative telehealth visit and can that be billed and how is that billed? And you were exactly correct. It is a telehealth service. Certainly we had telehealth defined prior to COVID. 1135 just opened up who can do it and a little bit of leniency with some of these types of services. So it didn't change that we already had defined services, and in that, preventive health is absolutely defined as a covered service through telehealth. But with that said, I'd like to say, I'd like to talk about the three different types of telemedicine services that we're getting a lot of language from CMS about. And that's the telehealth visits, virtual check-ins versus the e-visits. And I have really appreciated all of the workflows you all are sharing with your multiple specialties, as that helps us from the billing side, understanding that workflow and how that claim is being built because it's beginning at check-in. But the telehealth visit, the defining factor for what that telehealth visit is of course that live or that live exchange between the provider and the patient. This can be for established patients, and the new update is the fact that we can also now administer to new patients. So, we have a big difference of our, with who we can service in our communities because we can now also handle those new patient through telehealth services. So some of those CPT codes, of course, we're familiar with our regular E&M codes, that 99201s through 99215s. The most notable change with these is just like you said earlier, I forget, I forget which provider it was. I'm so sorry I didn't write down the name. However, your billing team is going to take care of those necessary modifiers, and that is correct. So just as you would normally document the components of a visit, that will give you the level of service, that 99212 versus the 99213. Those documentation requirements are still a standard. So that part of the workflow has not changed. So it's necessary that we do have that standard of visit. But in addition to that, I want to notate that I know that we're struggling as a clinic um, with that physical exam. And we know that that physical exam is a large portion of getting that appropriate coding. And I want to remind all of our providers that there's two very important pieces of the visit that we want to be very consistent on. And the first one is consent and documenting that consent, whether it's required as a written consent in your state or if it can be verbal only, and making sure that that information is documented in the note that it was gained prior to the visit commencing. And the second item is also the time that you're working with that patient, counseling them, because what we often forget is that we're so accustomed to meeting the three different components in any type of visit, that these are also time-based codes. And documenting the amount of time that you have spent with your patient and indicating that more than 50% of that time was allotted to counseling the patient, you're able to use the higher code should the amount of time spent code you higher than it be the components if we're not able to hit all three components to get the higher base coding. So again, use that time-based coding if you need to elevate the code that comes out of the component billing. And here we have a couple of G codes listed. All of these, of course, are still rendered by our usual billable providers, and we would still maintain that usual course of care of who can render the types of services through telehealth, just like we would in a face-to-face visit. The second item is the virtual check-ins. I know we've talked about virtual check-ins. The biggest difference is the virtual check-in is just a 5 to 10 minute conversation with the patient, and there's no level of medical decision making in a check-in. This is a decision of, do they come in? All we're saying is, okay, you know what? You need to come in for a test, or better yet, you need to go straight to the emergency room, or just stay at home and we'll follow up. Those are just, we're not rendering any type of assessments or plans. We're not doing that medical decision making. We're just determining what's the next step, and for the patient to follow up with an appointment. And that's the biggest differentiating factor. You've talked about asynchronous and synchronous communication. Those codes are the G2012 or 2010 that would drop for that new or established. New is a brand new update over the course of the last week, as virtual check-ins previously were only for established patients. And again, these two have to be rendered by that billable clinician. This cannot be performed by a nurse or an MA, and that's a big piece of that workflow, because this may very well develop into a full telehealth visit. So, and those two items cannot be billed together: the telehealth visit or the virtual check-in. If it remains just the virtual check-in, then we're able to take that and make a claim out of it. But the next item is an e-visit. I want you to be aware the greatest difference in that is the fact that this is a video conference through a secure portal. So any type of communication with the patient through a secure portal, and I said video conference, we do know that that there's been lots of communication that has lifted the video requirement. That is still a per payer, per state guideline that they will have to define the requirement for that if they will allow telephonic only. So, but the e-visit is through that secure portal. So you do have to have a platform that allows for that to happen, that exchange to happen through a secure portal. Whereas a Zoom product, I listed, the products you guys have, and WhatsApp, those are not, those items would not be appropriate, but we would be able to go up to the telehealth visit and use those codes. We have some resources here that talk about these items that comprise of some big different types of telemedicine services, and also remember that under the 1135 waiver, if a month ago you were not rendering a telehealth service, we can using these codes, and these codes will help us get us the maximum amount of telehealth reimbursement. And lastly, I think you guys have done a great job of discussing what the appropriate platforms are to use, and that you guys aren't going to be using anything outside of what's recommended, but they have been very clear, they being the government and CMS coming out with Facebook Live and TikTok. Those types of social media platforms are certainly unacceptable because we all want to maintain as much patient privacy as we possibly can in this new environment. But let's move to the next slide. All right, on this next slide, these are some, I want to talk about the diagnosis code changes. And certainly we know that all of our telehealth visits, majority of these will not be a COVID-related visit. And those visits will continue to be coded just as if they were when you were inside the four walls of your brick and mortar practice. So we want to maintain usual guidelines for our usual visits, but I want to specifically call out diagnosis codes for the COVID, for those COVID treatments. Now, prior to April 1st, the CDC was quite clear on the diagnosis codes and how they would be used and what would not be appropriate to use. I have these outlined here for you under the categories that the CDC has identified that it's appropriate to use as the diagnosis code based off of the condition the patient presents with. So one of the things I wanted to note, though, is item 1 on the footnotes of this slide. One of the items called out, or the diagnosis code, is diagnosis code B34.2. This is a coronavirus infection unspecified, and this was absolutely indicated as not appropriate as a billable item. So if you want to stay friends with your biller, you will not use the B34.2 dealing with a COVID case, okay? We don't like those unspecifieds, of course, but the CDC has made it clear that because we know that this is presenting as a respiratory issue, that it would be inappropriate to use an unspecified, and we should look to that B97.29 if to indicate the appropriate coding for that. Now that is pre April 1st. We know to expect new diagnosis codes to be released in October each year. Well, this emergency code U07.1 was released early as part of the emergency release for the public for the pandemic right now, and that's U07.1. And for dates of services, April 1st going forward, that is the appropriate code when we have the confirmed COVID acute respiratory disease. So prior to, we would use the items indicated above based off of the symptoms. It would typically be coded based off of symptoms, but going forward, once it is confirmed, we need to use the U07.1. And that's, so your billers will take it from there. But I want you guys to be aware, if you don't have that in your diagnosis code list, we want to definitely have that added to your favorites list or whatever template, however you have that set up in your EHRs. But know that that is from an April 1st date going forward, U07.1. Again, I have some resources here that's come from the AAP, from AAP, as well as other items that will give it in the CDC that will give us some additional resources, because these are changing on a regular basis. Very quickly, the important item to note with Medicare, and your biller is going to be super aware of this, there was a little bit of back and forth with CMS about your home address when dealing with telemedicine if you're using your home office. That expectation of registering your home address has been rescinded. We need to make sure that your services for your Medicare patients are being rendered in a typical, usual documentation, and the claim is being submitted as such. So if I'm your patient and I have a we won't say upper respiratory, I have some type of allergy reaction, and I call you, show you the rash on my skin, and you tell me to take some Benadryl and whatnot, you would still record that as a usual office visit, and it will be billed exactly as that. And you guys were correct that your billers know that we're going to update that modifier, indicate that that did happen through telehealth, but it would still go over as if you guys had seen me in person inside your office. And that's what we're trying to maintain mostly, is that consistency and something in an environment that is so inconsistent. Those are some tips that I have for today. Just want to talk about those the items that the CPT codes and the diagnosis codes that we've seen the most variations on, and want to reiterate understanding what the differences are in those types of visits. The modifier appendage, we're still going to honor those modifier appendages on the billing side based off of the appropriate billing guidelines. And then lastly, understanding the differences between the state laws versus the federal mandates, and understand that may not happen as quickly on a commercial or a state level as it's happening right now at federal level. I'm certainly available to follow up with any questions. And Terry, I want to thank you and HCN, Alex, and everyone for inviting me to be a part of the a panelist today. And I certainly want to thank you all for what you are doing for your community.
Lynn, thank you so very much. This is an excellent high-level overview of billing and coding for many of our providers who are on today's call. We did get a lot of questions, but we're tight on time. So again, we're gonna collect all of the questions that were put in the chat. We will get responses from each of the panelists for those questions, and then put out a document, an FAQ document for today's webinar. And then also, I'm reminded by our staff that today's webinar is recorded. We will be emailing out to everyone the recording link to the webinar, along with all of the slides that were presented at today's webinar. So I think we have one more agenda item and only 5 minutes. So we have one more quick polling question number 4, and then we're going to go on to our last agenda item. So what other assistance do you and your health center need with advancing telehealth? You can choose all that applies. So it might be on your individual provider level or at a health center level, but what other assistance do you think that Health Choice Network and Alliance Chicago can help you at your health center level with advancing telehealth, meaning moving through this COVID period, which eventually hopefully will end. It will end. And we will now be into a new world and space where we're using more telehealth. So Stephanie, let's look to the answers of our last polling question. And it looks like billing and coding and also patient engagement, which we didn't talk too much about today, are two of the highest ones. So patient engagement is something that we definitely will be able to look more into and help health centers with that, definitely billing and coding. And then bringing on the provider and care team engagement and using the right platform to make sure that everyone is engaged. And then truly, we do know that health centers would like to have some real hands-on experience and training on real-time documenting in EMR, whatever EMR you're using, while you're doing a telehealth visit. So we will more to come on that. That's a little seed for some people who, if you want to hear about that. So next, I would like to turn it over to my colleague, Julian, who's going to talk to us about some telehealth user guides. Julian?
Hi. Yep. Thank you, Dr. Long. Hi, everyone. For anyone who was not on this webinar last week, my name is Jillian Javed, and I have been working with Health Choice Network for over 3 years now as a clinical informatics specialist. So today, I'm just going to talk, like Dr. Long said, just a few quick minutes to show you some of those telehealth user guides that we've created. So early on, both Health Choice Network and the Alliance Chicago recognized that every center is unique in how they needed their needs met for telehealth, and that meant that there was going to be various platforms being used, especially in a time of rapid adoption. So what we did, we put our feelers out and polled all the networks to see what are the most common softwares that were being used for telehealth. And what we did was we took the three top, which I think we learned today with all the polling questions and discussions, that really Doxy.me and Zoom are definitely on the highest usage. So we've created 3 different sets of documents for Zoom, for Doxy.me, and for WhatsApp, just so we covered all of the most common bases. And we created several documents. So there's 12 in total, 4 for each of the different platforms. And they really run the gambit of different scenarios. So some of them are patient-facing, so you can utilize those for your patients and trying to get them the education that they need on how to download if needed, or how to launch those sessions. And then we also have your staff. So both the clinicians, when they're launching those applications or downloading any needed software, and for the clinical teams when they're doing the same, when they're scheduling or getting those appointments set up for you. So there's a lot of variations, a lot of good places to start. So what I'm going to do today is just kind of show you quickly how you can access these documents, as well as Dr. Long previously mentioned that they are also in the handout section. So what we did, if you are interested, we'd love for you to take a look at them and see how you can utilize them with your current workflows. So what we did, you'll see 3 different handouts, each one for each software, and we combined those. So while there's 4 different handouts, they've been condensed into one PDF. So if you're on Doxy.me, just go ahead and grab that one handout, and that will have all of the workflows for you. So if you're not able to download them today or you want to access them in the future, they are currently located on the COVID-19 resource library that is found at www.hcnetwork.org. And I will say that although this is located on the Health Choice Network website, this platform is accessible to everybody. So no matter if you're with Chicago Alliance or you're with Health Choice Network, you can navigate to www.hcnetwork.org and access the entire resource library, not just the areas I'm showing you, but you have access to all of the wealth of information that is coming in regarding COVID-19. So you'll just quickly go into your browser. You'll go to the hcnetwork.org main website. Then you will find in the upper right-hand corner the COVID-19 resource library. Once you're there, you'll start to see the abundance folders with all different topics of COVID-19 materials. And for these particular user guides, you'll go to Telehealth Resources. And then once you get into that one, it'll further break it down into sections, and then you'll navigate to the Telehealth Software User Guides. So you can go to the next slide. Perfect. So I just wanted to have a quick screenshot of what one of those documents looks like. So what we really wanted to do was make this as easy as possible for the patients and the staff members. So not only do we have it in step-by-step instructions, but we also try to use as many quick screenshots as we can to help guide them through that process, what they might see different if it's their first time launching, meaning do they need to allow access to cameras and microphones and notifications? So if it is their first time, what might that variation look like? And really give them that easy, quick step-by-step. So hopefully to mitigate any questions that they have and prevent the need for any, of your support team's involvement in kind of getting these patients and your staff up and running. So again, I encourage you, if you're using any of these platforms or you're considering using these platforms or you haven't quite decided, go ahead and download them, take a look at them and see how you can integrate those into your workflows today for both your patients and your staff. So that is it for me today. So I will turn it over to Dr. Long.
Great, thank you very much. That is great resources and guides for any health center at Health Choice Network and Alliance Chicago. And these are free resources that both network staff have put together for our use at the health center. So that concludes today's webinar series in responding to COVID-19. I would like to thank all of our excellent panelists today for the time that you put in to tell your story and your health center's story about COVID-19. We will make it through this period, and we will become hopefully a better system of healthcare with community health centers across the country. The more we work together, share our experiences, and share what we're learning and share what has been challenging, we will become a better system in the future. Telehealth definitely is going to be the tool that we'll be using more into the future. So again, we want to thank everyone. We are grateful for all of our community healthcare heroes. We at the network level want to make sure that you think of us as an extension of you and your health center. We are a part of you, and we want to make sure that we are able to meet your needs. So please let us know, reach out to us if you have any questions at all. We will be repeating, again, another webinar next week, next Wednesday. We'll send out the details and logistics of next week's webinar series for community health centers. And hopefully everyone has a great day. Stay healthy, stay happy, and make sure you get enough rest. Bye. Have a great day.